Good day, everyone, and welcome to the OrthoRoCKs webinar series. This is an initiative of the Department of Orthopedics, University of the Philippines, Philippine General Hospital. The OrthoRoCKs webinars are held every Saturday of August 2018 from 12 noon to 1:30 p.m. Manila time. The webinars tackle common orthopedic problems and are targeted for medical students, residents training in orthopedics, primary care physicians, orthopedic surgeons at large, and other health workers. Registration is free, and this webinar series comes with 5 CPD units. Certificates for attendees will be given within 2 weeks after the webinar. Again, please fill up and submit the registration form in order to receive your CPD certificates. This webinar runs on UP Manila live stream. You may also view the webinar via our OrthoRoCKs live Facebook page. If you are encountering problems joining us, please hit the refresh key and rejoin us on livestream.upm.edu.ph. You may send in your questions through our chat room using the dialog box provided, or you may ask them via our Facebook live page. The question and answer portion will be held after the lecture and will be facilitated by our moderator. The webinar today will run for an hour and a half. The first lecture will run for 30 minutes, followed by a 15-minute open forum. The second lecture will then commence, also for 30 minutes, followed by another 15-minute open forum. Again, welcome to the OrthoRoCKs webinar.
Good morning, Dr. Albert Pintos, and I'm speaking from the video conference room of the University of the Philippines, Manila. And I'd like to welcome all our participants on this stormy Saturday morning. And today's first topic is on venous thromboembolism, and our speaker is Dr. Virgilio Genuino, who is a graduate of the UP College of Medicine in 1986 and is an alumnus of the department in 1991. He did his postgraduate clinical fellowship at the Hennepin County Medical Center in Minneapolis in 1994, and he specialized in joint replacement and adult reconstructive orthopedic surgery. He is currently an active staff consultant at the Department of Orthopedics of the Makati Medical Center and the Manila Doctors Hospital. And for me, more importantly, he's the father of 5 children, one of whom is presently a resident here at the Department of Orthopedics, and he has 2 more presently in the UP College of Medicine. So we now turn you over to Dr. Virgilio Genuino for his lecture on venous thromboembolism.
Good afternoon. Yes. Before anything, I'd like to disclose that I am not receiving any sort of funds from any pharmaceutical company, and I'd like to thank Dr. Pintos for that very kind introduction, eliminating the bad ones. Anyway, the topic's on venous thromboembolism. First things first, you might be wondering what the heck is an orthopedic surgeon doing talking about something that is more appropriately discussed perhaps by a cardiologist or even a peripheral vascular surgeon. Well, it is an important topic for orthopedists because it's a big thing when it comes to joint replacements. My fellowship was on joint replacements, and we had to learn a lot about these things before we proceeded with joint replacements. Anyway, that's the topic on the board. Regarding VTE, shortcut for venous thromboembolism, there are 2 entities we're concerned with: deep vein thrombosis and pulmonary embolism. VTE is very common, often unrecognized. It's found in both hospitalized and non-hospitalized patients. It recurs frequently. Mind you, we have to remember this, recurs frequently. We'll find out later in the lecture why. It's often overlooked, and if overlooked, there are certain long-term sequelae like CPPH or chronic thromboembolic pulmonary hypertension and post-thrombotic syndrome. As usual, as in many diseases, it's a combination of both hereditary and acquired risk factors. So we have thrombophilics and states which are hypercoagulable. I guess this entails a review of what we learned back in medical school. Virchow's triad or Virchow's triad. I hope I'm doing Dr. Virchow a favor by saying by pronouncing it properly. So the three sides of the triangle, we have hypercoagulable state, endothelial injury, and venous stasis. An orthopedic surgeon is concerned with all three because we are involved in all three. For example, endothelial injury. Of course, we do surgery, so we cut up the patient, we injure some vessels, then we deal with trauma. Even initially, before we even manage the patient suffers trauma. Okay, then the rest, indwelling catheters, atherosclerosis, heart valve disease or replacement are the other entities in an endothelial injury. Another side is hypercoagulable state. We have the acute phase post-operatively. Once again, we are involved here as orthopods. In cancer, we will have a speaker later who will speak on bone tumors. So we deal with a lot of cancer in the bone. And other thrombophilic, we have thrombophilia. Perhaps for OB-GYNs, there's estrogen therapy, pregnancy and postpartum period. And we have inflammatory bowel disease. For venous stasis, the first item, once again, as orthopods, we are involved here, immobility or paralysis. The first thing we do after a trauma is we advise our interns, our students, to immobilize the injured area. And we put them in casts, we put them in traction, so we contribute to venous stasis. Other items in venous stasis are heart failure, venous insufficiency or varicose veins, venous obstruction from tumor, once again, we can be involved here as orthopods, obesity or pregnancy. In terms of prevalence, mind you, all the data I'll be citing are data from abroad. We don't have any much locally. So these are usually used United States statistics. It's the third most common cardiovascular illness. Approximately 1 million are involved or have it in a year. 2/3 of VTE result from hospitalization. Pulmonary embolism is the third most common cause of heart-related disease deaths. It is also the most common preventable cause of heart-related deaths. So that's another reason why we have to be familiar with this. Okay, risk factors among hospitalized patients: acute medical illness, infection, age greater than 75. So as orthopods dealing with joint replacements, we deal with usually elderly patients. So that's a risk factor already. Cancer, a history of venous thromboembolism, the presence of cardiovascular risk factors like hypertension, diabetes mellitus, smoking, and high cholesterol. And we have genetic factors. There's P-laden, prothrombin gene, mutation, etc. This is just an example of one of the risk score systems that were developed in assessing patients for VTE. Now, there is a plethora of risk score systems, and they vary by institution. Certain hospitals also have their own scoring systems. Now, as far as which ones are validated, I am not aware, but there are hardly any that are validated. So among the things they ask are these, like clinical signs and symptoms of DVT, that's calf tenderness, swelling of greater than 3 cm, erythema. So there are corresponding points for each of these, if positive. A review of pathophysiology. So venous thrombi consisting of RBC platelets and leukocytes, which are bound by fibrin, they form in sites of vessel damage and stagnant flow. Now, if they just stay in place, they may undergo endogenous fibrinolysis and recanalization. However, You might say that some of them have a wanderlust. They want to go traveling, so they embolize. Okay, for deep venous thrombosis, usually they involve the lower extremities. Proximal DVT actually has a 50% risk of turning into a pulmonary embolism. Now, distal DVT has 20 to 25% chance of propagating to proximal. And then from proximal, there's a 50% of becoming a pulmonary embolism. Upper extremities can be involved, but in a minority. Perhaps in orthopedics, we're dealing with potentially from IV insertions that went wrong, inappropriate use of tourniquets during surgery, even from casting perhaps, or improperly done tractions. Other vessels involved would be the mesenteric veins, pelvic veins, cerebral veins. Now, regarding pulmonary embolism, the pathophysiology have increased respiratory rate and hyperventilation, impaired gas exchange, so you end up with intrapulmonary shunting and hypoxemia. You have atelectasis and vasoconstriction. Okay, signs and symptoms of DVT. Well, there's general pain, tenderness, and swelling. So maybe that's why many times these things are just neglected because, you know, patient comes to you, it's got a painful calf. It's usually dismissed as just muscle pain, you know. So maybe we have to have a high index of suspicion, especially in patients with the risk factors. Warmth, edema, and erythema. Another thing that can be just put aside, and we'll just say it's just a cellulitis. We give antibiotics, send them home. So once again, we need a high index of suspicion. Now, a less common sign is phlegmasia cerulea dolens, the picture rightmost. Okay. Personally, I haven't seen one, but I'm sure the tumor surgeons among us have seen cases of this. I think it's more common. Signs and symptoms of pulmonary embolism. There's dyspnea, tachypnea, and pleuritic chest pain. Now, I could imagine if I were looking at the audience right now, I'd be looking like this in the slide. It's just fortunate that right now I'm just looking at the camera. Apprehension, hemoptysis, cough, syncope, and tachycardia. Diagnosis. The following can be indicated. Of course, a clinical diagnosis, you know, examining the signs, symptoms. Okay. There is D-dimer. Perhaps what I can say about D-dimer is it's more significant if it's negative, because if it's negative, at least we can rule it out. But if it's positive, we can't rule out other entities. There's duplex ultrasonography, which seems to be the modality of choice for diagnosing DVT nowadays. It was contrast venography, but it has fallen into disfavor because of potential allergies to the dye. In other centers, especially abroad, where they have a lot more money, they do magnetic resonance venography and CT venography. So yeah, the picture to the right shows what an ultrasound would look like, and a venography is seen in the left. The diagnosis of pulmonary embolism is also clinical, and once again we have D-dimer, ECG, chest X-ray, ABG, CT pulmonary angiography is another one. Ventilation perfusion scanning, biomarkers, pulmonangiography, MR angiography. In my own practice, I have the great fortune of having a great cardiologist to work with me, so I don't really worry about these things. Now, the dilemma among orthopods. Okay? It's always a balance between adequate VTE prophylaxis versus surgical bleeding. We all know that high risk among joint replacement patients, even among patients undergoing hip replacements or surgery for hip fractures, even in trauma. So our dilemma is when to start, how much to give, what to give, etc. Because with the timing going wrong and you do your surgery and the patient has really what we call dilute blood and keep bleeding during surgery. Okay, once again, we have a high rate of VTE in orthopedics because of the release of thromboplastin from dissected soft tissue. And yes, we do ream bone. Orthopedic surgery, especially for joint replacements, is not necessarily a very elegant procedure. So there's a lot of rough housing, maybe, a lot of carpentry being done, and yeah, we do a lot of this happens. Another thing is post-operative immobility, because we don't just move the patient immediately after surgery. Although in joint replacements in certain centers, within a day or two, we get them walking to mobilize. We have to deal with side effects of pharmacologic prophylaxis. Now, with excess bleeding, post-operatively, we have prolonged recovery. So you have a wound that keeps leaking blood. Somehow that will delay healing also. So you're more prone to wound failure and potentially an infection. Because if you have a hematoma, that's a very good medium for bacteria. And we'll have a bigger problem if ever we develop an infection. I could say that in my generation of orthopedic surgeons, we grew up in an atmosphere of what I call thromboskepticism. Okay? A lot of our old professors would tell us, oh, VTE, that's just a problem among Caucasians. However, So they would say that whereas thrombosis is an act of God, bleeding is caused by surgeons, by all our efforts to do all of, for prophylaxis for VTE. So that's one of the old things. And in a way, my generation, we grew up in that kind of an atmosphere. What I was surprised to find out is with a big study in 2008, Sharak found out that there is no clear change in mortality rates with or without prophylaxis in orthopedic surgery. So does that justify not giving prophylaxis? Perhaps. Another thing I found out in my readings is that symptomatic non-fatal VTE rate is only 3 to 4% without prophylaxis. And there's actually no different. It's no different from increased bleeding rate induced by pharmacologic prophylaxis. Still, another thing is the incidence of asymptomatic VTE is 20 to 40%. So the patient might have it, but they don't feel it. So we're not aware of it. However, prophylaxis in joint replacements is universally justified. So most clinical practice guidelines would say, yes, you have to do it, even among Asians. And things to consider are the time of initiation, and the duration of prophylaxis. Of course, you have to assess thrombosis risk versus bleeding risk. That's why we have all of these scoring systems. And of course, cost effectiveness. A lot of these new drugs can be very pricey. Not a problem in first world, but in third world countries like ours, it might be a problem. Now, prophylaxis is not just chemical, drugs. We also have general types of prophylaxis like early mobilization. Now, I remember during the time of thromboskepticism, some of the older consultants would say, oh, just do ankle pumps after surgery and that should be sufficient, and then get them walking. Then you don't have to do any kind of other prophylaxis. So yeah, in most studies that I've looked at, nobody even mentions ankle pumps, but it's just a simple thing to do. Of course, careful surgical technique. Now, yeah, it comes with experience. Usually, it becomes easier to do with less blood loss and adequate rehydration. The picture shows a typical picture of how an orthopedic surgeon views adequate rehydration. Other non-chemical prophylaxis are mechanical. There's the use of graduated compression stockings, readily available, and mechanical foot and calf compressors like the device shown bottom. Okay, now, these are available locally, but they can be pricey. Now, the only problem with this is that the mechanical foot calf compressors can only be done inpatient. Abroad, they can even send the machine home with the patient, but the next problem abroad is compliance. Do they really use it? Although some have monitors to check if they are being used. Well, in a local setting, sometimes we don't have to worry about it. We have the guardian or the bantay of the patient immediately post-op. The first thing they do usually is massage the legs of the patient. So they don't mention that in literature either. Um, Usually, these compression devices, even abroad, they start it in the contralateral leg, even intra-op, because the chance for VTE or the risk for VTE starts at the start of surgery. So abroad, during surgery, these are even used in the contralateral leg. Well, neuraxial anesthesia, spinal is actually recommended for joint replacements because it reduces VT and overall mortality rate. However, we have to know, although the anesthesiologists are aware of this, we have to assess the risk of neuraxial bleed because if given at the wrong time, you could end up with bleeding um, into the spinal canal, which could be a big problem, and you'd have to call a neurosurgeon to drain that. And even just inserting an epidural catheter and its removal has to be timed right. Because if removal is done during a risky period where patients likely to bleed, you could also cause a neuraxial bleed. Okay, chemical prophylaxis. There's the good old aspirin and the good old warfarin, relatively low cost. However, recently have fallen into disfavor. Late literature would would villainize aspirin as having so many side effects, gastrointestinal, etc., and very inconsistent results with it. Now, with warfarin, um, the trouble with this is the constant need for monitoring INR, which could be costly and a bit painful for the patient. Another one of the older ones is unfractionated heparin. Now, this has also fallen into disfavor because of the need for frequent monitoring of the PTT and the incidence of heparin-induced thrombocytopenia. Administration is also another thing that goes against it. Although, yeah, relative to the newer drugs, it might be more cost-effective. What seems to be the trend now for the past 2 decades also is the use of low molecular weight heparins. Studies, although I have to state most of these studies are industry funded, show a lower bleeding risk compared to the older prophylaxis agents with a better predictable effect and no need for any kind of monitoring. And even lately, we have the new oral agents. They're practical for long administration because they're taken orally. And once again, industry-funded studies say that there's greater efficacy than aspirin. You avoid monitoring and potential drug interaction. So there are 2 general types. There's the anti-10A and the direct thrombin inhibitors. Is this a short chart to show where these agents work in the cascade? And another chart to show where they all act in the cascade. Perhaps an internist will be in a better position to discuss the medical treatment or of BTE. Okay, the start and finish of thromboprophylaxis. I stated earlier that the thrombotic process actually starts at the start of arthroplasty, or let's say any kind of orthopedic surgery. So the best time is as close to surgery as possible. So it's always a race between too close versus too late. Now, if given preoperatively, it's subject to all kinds of, you cannot exactly time it perfectly because sometimes there's a delay in the start of surgery. So if you order it for an hour before surgery, there might be a delay when it comes to transporting the patient or moving the patient into the operating room, positioning them in the operating room table. There might be a delay also in the administration of anesthesia. You cannot possibly time an anesthesiologist when he does a spinal or epidural. So more consistently, it can be done post-operatively because there's a definite, time when the operation is finished. So it's more reliable time-wise to give it post-operatively. But each center has their own way. Where I worked, the prophylaxis was started 12 hours before and it's continued for another 2 days. The duration of risk for total knee arthroplasty is 2 weeks. It's a little longer for total hip arthroplasty. So the recommended period actually by the American College of Chest Physicians is from 10 to 14 days with further suggestion to continue it for 35 days post-op. However, the suggestion of giving it 35 days more seems to be from studies, once again, that are industry funded. It can be confusing because there are so many guidelines available. I only put in my slide 3 of the more popular ones. Okay, that by the American Association of Orthopedic Surgeons, which us orthopedic surgeons try to follow. The latest one of which is like 2011. The American College of Chest Physicians, with their latest guideline, seems to be more in tune with what the AAOS has. But prior to that, they were at odds with each other. So there are different recommendations given to chest physicians compared to orthopedic surgeons. Then there's the NICE. It just only means National Institute for Clinical Excellence. I think that's in the UK. These three seem to jive with each other, for lack of a better term, jive with each other in terms of recommendations. So just to elaborate on recommendations of the American Association of Orthopedic Surgeons from 2011, just as in the other two, post-operative duplex ultrasound screening is not exactly recommended. It doesn't do any, it doesn't really add to the treatment. It's not necessary. Of course, determining a previous VTE, knowing that it recurs frequently, is very important. So clinical assessment has to be done prior to doing any surgeries. And likewise, we assess for bleeding disorders. So it's, the patient might lean towards one, more towards developing VTE or more towards bleeding disorder. So you have to find out where the patient lies in the spectrum. It's recommended to stop the antiplatelet agents prior to surgery. Now, with patients without elevated risk for VTE, it's recommended to do mechanical and/or pharma agents for prophylaxis. Those with elevated risk, both are recommended, mechanical and pharma agents. Now, with bleeding disorders, just mechanical prophylaxis is recommended. And once again, early mobilization, Neuraxial anesthesia is also recommended. And the use of inferior vena cava filters is no longer recommended. Doesn't make any difference in terms of outcome. So I believe that's the last slide. And thank you for your attention.
Thank you very much, Virgil. And we now go to the Q&A of this session. We'll just try to see the questions that have been posted, but I'd like to start off with a particular question. Virgil, you were saying, I guess our dilemma is what exactly is the incidence of DVT here in our setting in the Philippines? So, does it really warrant mechanical, well, definitely mechanical, but pharmacologic prophylaxis? And I think I remember the study that was presented by actually Dr. Wang. Is he already here? Some time ago, wherein I think the incidence that they quoted was around 12%. And the recommendations at the time was definitely mechanical prophylaxis and then still going with pharmacologic prophylaxis. Can you comment on that?
Well, there are several studies already, even in Asia, regarding this. However, some of them say that it's similar to statistics with Caucasians. Some of them say it isn't. So, you know, it reminds me of one of my older professors telling me, if you read a lot, you go through all the journals, you read all the articles, you'll find articles favoring one and others that favor the other. And you end up with a paralysis of analysis. So yes, there are several studies. Many of them say that it's no different from Caucasian levels. And others are stating that it's different. So if you ask me personally, I would err in the side of giving. Because if it's like, if you err in terms of commission than of omission. I think there are even older studies done by Dr. Tanchuling locally.
Yeah.
And they used ultrasound to find out the levels. And their recommendation was, it seems to be similar to Caucasian levels. So yeah, maybe we should earn the commission.
Okay, I'm going to put you in a spot and ask you right now, what would your recommendations be in terms of those undergoing hip or knee surgeries now in our setting? And maybe you can also share what you actually do in your own practice.
No, in my own practice, once again, I'll state that I am fortunate to be working with a lot of good cardiologists. Sometimes I confer with them, and most of the time I leave it up to them. Yes, most of them would recommend doing the prophylaxis. They all have their own favorite drugs. Depends also on which hospital I go to. And then they also have their own favorite times of when to start, before or after. So if you're going to ask me, put me in the spot, I leave it up to my cardiologist. Although I also put in my 2 cents, after assessing the bleeding risk or the VTE risk of the patient. And then we come up with a consensus. So yeah, maybe that's all I can say for now.
I think that's how most of us actually do. But there seems to be a big trend now towards really early mobilization, even the type of anesthesia that is being done now, regional anesthesias, nerve blocks, and most orthoplastic surgeons sometimes want them already mobilized later in the afternoon. So I think that's also a big thing in terms of favoring mechanical prophylaxis more than pharma prophylaxis.
Okay, maybe I could add to that.
Yeah.
Locally, I don't think we even have a problem. I remember my experience in the government hospital, PGH, we always have the guardian or the bantay. Even without telling them they're there, they'll start massaging. And then even ankle pumps. We just simply say ankle pumps because, the government hospital, you can't afford all of these mechanical pumps, etc. And yeah, abroad, early mobilization is always the thing. I remember in the center I worked in abroad, the following day, they get them up on their feet, whether it's a hip or a knee replacement. And the patients oblige. But then again, I found out it's because most of them, they have the insurance pay for it. And insurance will only cover for 2 or 3 post-op days. So they really have to get out of there, else it's money out for them. locally, you can't just tell that to Filipino patients. I guess, get up, maybe take another 2 or 3 days. But you have the bantay there encouraging, doing the massaging. You could always encourage them to do ankle pumps. And that's the cheapest way to go, I guess.
Here we have a couple of questions that I'm sorry I didn't see earlier, but this is from Cami De La Rosa. Should prophylaxis be stopped once a patient is already walking?
There you go. That's another thing. Depends on which cardiologist I'm working with. Well, yeah, you would think after the patient starts moving, then you don't have the risk. But then again, you have some other studies of the ACCP saying that they recommend another 35 days because the VTE risk goes all the way to around 6 weeks. So if you want to play it safe, maybe if you don't want to do chemical, you can always do mechanical post-operatively. I remember in the center where I worked abroad, we'd put them on stockings for like 6 weeks. So that's a kind of mechanical prophylaxis. So once again, maybe it depends on which cardiologist or who is my cardiologist that I'm working with in the case. And I also assess the relative risk of the patient. Of course, if there's a previous history of VTE, then maybe we'd be more aggressive with the chemical prophylaxis. So once again, 10 to 14 days recommended, but an extension up to 35 days is suggested. Anyway, you can go oral by then. You don't have to administer it subcutaneously. You have so many of these new oral agents. I'm not favoring any, mind you. So that'll all depend on what's the favorite of my cardiologist, perhaps.
And as a follow-up to that, also from Tammy, there are many oral pharmacologic agents now in the market. Are they more advisable than the injectables?
Okay, if we go by the studies currently, although most of them are industry funded, they have a greater safety factor, allegedly. Okay. Cost effectiveness, better than maybe administering it by subcutaneous or IV. Better safety profile, no need for monitoring. So the studies sort of point to them as being the way to go. So in terms of preventing VTE, they're actually supposed to be better than things like enoxaparin. However, there are also studies that show that they have greater incidence of bleeding disorders with use of this. So if you ask me once again, it's kind of like the jury's still out. I mean, it'll take another several years before we find out which among this is really safe. However, here's a thing I found out. Somebody reviewed all of these studies, and the majority are actually industry funded. Okay, and if it's industry funded, they found out, of course, the favorable result regarding the drug is higher. When somebody looked at the non-industry funded studies, there's actually a 24% that it doesn't work, or it doesn't really do what it claimed. Well, if you look at industry funded studies, only 6-7% show that it doesn't work or it doesn't do anything. So that's what I meant by if you read a lot, you get more confused. So I guess the jury's still out regarding that.
Okay, so far those are the questions that have been called in, and I think Dr. Genuino has adequately answered them. So at this point, we can close this session for our webinar series, and thank Dr. Genuino for that very informative talk on DVT prophylaxis and DVT in general. Thank you very much.
Thank you.
Virgil. Thank you. And please join us for the next one in a few minutes with Dr. Edward Wang.